Today we're going to talk about, we have 4 panelists, and I'll introduce them briefly here in a second. I'm intentionally being brief because I don't want to take too much time here to maximize efficiency and their amazing content. I'm just going to sort of give a brief intro and then we'll roll right into it. We have 4 presenters. Each one of them will have a set of slides that they will present. And then at the end, we will have a 15-ish or so panel, a Q&A, sorry. So I ask you either A, hold your questions until then, and we'll use the raise hand function and call out, or feel free to chat them, put them in the chat. We can kind of like sift through them as we go. So if you have a question that comes up, if you feel like it won't be answered in the subsequent slides, put it in the chat, or you can wait till the end and we can use the raise hand function. So this is alphabetical order. Today we have Vanessa Healy. She is the SUD and Behavioral Health Coordinator for New Hampshire 211, which is a Granite United Way initiative. We have Chris Kozak, the Chief Operating Officer with Community Partners here in Stratford County. Nadine LeMontagne, Community Engagement Manager for the Unitas Care Coordination Network platform in New Hampshire. And we have Jennifer O'Higgins. She is a Senior Policy Analyst for the Division of Behavioral Health within the New Hampshire Department of Health and Human Services. So I guess we are ready to go, Ashley. This is the slide deck. First presenter. Let's hear your stuff. Thank you.
Hi, so I think I'm up first. I actually am going to open with a video. So Ashley, I'm not sure if you want to pull that up or if you want me to do that. Oh, nope, you're ready to rock. Okay, awesome. So we have just a brief 4-minute video. It's going to give just a little bit of an overview of the vision of Crisis Now, which is just a national model of crisis system transformation for behavioral health. And that'll help us frame, theoretically where we're going as a state. And then I'll talk through where we are today in New Hampshire. So we don't have the sound right. So if you, I'm not sure if it's Ashley that is sharing screen. But you just need to make sure that when you do share screen, you have to click the buttons that say share audio. And then, and then just start again. You may want to stop share. And then when you hit share again, there'll be like little buttons at the bottom that say share audio. And I'm happy to Google it right now to pull up the video in case that's helpful.
Imagine for a moment that a fire breaks out in your home, and in this reality, 911 doesn't exist. You might call the fire department directly, but they're not equipped to come to your location and only put out fires at the fire station. And the only people that will come to you in the community are the police, who, though well-intentioned, are meant to provide a very different type of public service. This lack of a fire-specific response seems ridiculous, right? Of course we should have targeted services to respond to life-threatening emergencies, whether that's fire, law enforcement, or physical health. However, in many communities across America, life-threatening mental health and substance use crises are treated as an afterthought, receiving a response that's not specific to their unique needs. A 911 call dispatches the police, who most often bring the patient to a medical emergency room or jail, or allow them to remain in the community but without assessment, treatment, or support. We have a patchwork system, made up of elements designed for other purposes, that doesn't have the capacity to treat the most vulnerable in our communities, even though an estimated 20 to 25,000 individuals in crisis go to emergency departments every day in the US. So how can we improve? The only solution to delivering crisis care worthy of our communities is to build a structure specifically for mental health, substance use, and suicidal crisis that is on par with other emergency systems, like we do for medical, fire, and law enforcement. By integrating 3 core elements, we can replace the patchwork fabric of our crisis care and develop a true safety net that can serve everyone, everywhere, every time. And in the process, we can reallocate wasted financial resources to places where they can have a deep community impact. It starts with regional or statewide crisis call hubs. call, text, and chat lines staffed by trained professionals who answer the call every time and direct people to the level of care they need. The onset of 988 is a great start. However, it will need to be supported by technology that empowers 988 to become an air traffic control for mental health and substance use crisis, enabling real-time coordination across the care spectrum. But a comprehensive crisis network cannot be built with only crisis call hubs. Additional services are necessary to ensure that a unified system of care is available when and how people need it. Services like mobile crisis outreach teams, 24/7 non-law enforcement mobile teams that go out in the community and deliver care to people wherever they are. This lessens the burden on law enforcement during situations where they're not needed and eliminates the anxiety people feel when a uniformed officer knocks on their door. And facility-based crisis receiving and short-term stabilization, facilities that say yes to every person that walks through the door, regardless of their level of need, allowing them to bypass the medical emergency departments. This not only provides specialized care to these individuals with less waiting, it also enables medical emergency departments to focus on the patients they're trained to serve, while drastically reducing wall time for police when transportation by police is warranted. With these core elements in place, mental and substance use healthcare can move out of the shadows and into the mainstream. Together, we can build an unbroken system of care that connects patients from the point of crisis to the level of care that's right for them. To learn more, visit crisisnow.com.
Okay, awesome. Thanks, Ashley. So just make sure you click out of that video, because what happens to me every time I share these, the next YouTube video randomly starts playing while I'm talking. So lessons learned, you've got to shut down that screen or you'll be playing some other random video in a minute. So I like to just use that as our starting point, because I think it gives you sort of that visionary, this is what we want to have someday system, right? So it's the idea of the promise of 988 and this now model is pretty big. And crisis transformation does not, I mean, no transformation happens really, really quickly, right? So it's sort of the long-term plan for the state. So a lot of you may be very familiar with the 10-year mental health plan. One of the core recommendations of the 10-year mental health plan was to transform the way that children, youth, adults, and families all access mental health and substance use care in New Hampshire. So for many people, their access point to mental health services was the hospital emergency room, right? And in New Hampshire, we felt like we knew we could do better. So advocates, stakeholders, and elected officials came together around creating a shared vision to drive these solutions forward. And over the last 2 years, I've kind of gone from concept into contracting some of those components. So when we look at this graphic, it already kind of needs to be updated because we've already taken it a little bit further than where this graphic is today, but it is at least a nice starting point for us to talk about what it looks like today in New Hampshire. So what I like about that video, in addition to it kind of setting the stage for us, is taking some complex issues and making them pretty tangible to understand. So these 3 pillars of someone to talk to, someone to respond, and somewhere to go. We had, when 988 became federal legislation, where the federal legislation said, we're going to take the National Suicide Prevention Lifeline phone number, 10 digits, that's been around for a number of years, and we're going to create this behavioral health crisis line modeled after 911, right? So in the way that you know to call 911 when you need police, fire, or ambulance, we're going to create a way that you could call to de-escalate a behavioral health crisis. And when the FCC was charged with figuring out what that phone number would be and doing a ton of research and reporting on what the phone number should look like and how it might connect to other phone numbers. And the National Suicide Prevention Lifeline was the selected sort of existing network, because there's a network provider in every state, and because there's some existing national infrastructure to that call line. They decided they'd use that call line, but they'd expand the serviceable population so that all of the marketing and everything for that line was not specifically called like Lifeline and not specifically naming suicide, but to really open it up that people should call kind of emotional distress. And that could be inclusive of mental health, suicidality, and substance use crises. And so those changes are coming, for on that national scale. And 988 go live date is July 16th of 2022. Now in New Hampshire, there was already this planning underway. The 10-year mental health plan came out in 2019. And so this really large group of stakeholders, community members, folks with lived experience had all worked on what do we want it to look like in New Hampshire. So right now in New Hampshire, we're in this sort of funny place where we've started to implement some of the goals, and then 988 is going to be layered on top of that. And even though it's all in line with moving in the same direction, there's going to be a period of somewhat of confusion with the phone numbers. Right. So I'll just kind of name that as a challenge and something that we all as providers and caring community members, we want to just be clear about it so that we can get to a place of understanding and then continue to clarify our message over time. So right now, we received a small planning grant for 988 to try to figure out how to implement that. In many, I think all but 2 states received the same planning grant. So we were a part of a national community of practice, learned a ton from the Crisis Now model. When we started that planning grant, we realized that New Hampshire had more than 30 potential phone numbers to call, text, or chat in any kind of behavioral health crisis. So the 10-year mental health plan and this Crisis Now model both call for like a centralized access point, one place that we can call, text, chat. It can be 24/7. It can be, an easy, accessible place, and not all of these different phone numbers. And I have to figure out sort of which one is going to be most accessible. So on January 1st, the state DHHS entered into a contract with Beacon Health Options to operate that centralized access point. So that service is now live, where the someone to call piece of these 3 pillars, there is now 24/7 call, text, and chat to de-escalate crisis situations, and it is open to that broader audience that I had talked about. The mobile crisis outreach teams is another piece, that someone to respond. That piece is also, being worked on today in New Hampshire. So as a part of the changes that happened January 1st, we previously had 3 community mobile crisis teams in the 3 urban regions of the state. So just Manchester, Nashua, and Concord had these mobile crisis response teams. And with the change that happened January 1st, all 10 community mental health centers began to stand up mobile crisis response teams. Now, Chris is going to take over right after I talk about this sort of longer term vision, and Chris can tell you a little bit more in depth what that looks like locally and where we are today from a more realistic standpoint, instead of where I'm thinking we might be in 5 years, right? So he'll be able to take you down to the level of like, what's it look like today? But all 10 community mental health centers have some level of ability to now operate these mobile crisis response teams. And then the somewhere to go component of that 3rd pillar is something that the state continues to work on. So there are some walk-in availability at our community mental health centers, and we're also utilizing some additional supplemental funding to look at technical assistance about where in the state we should locate crisis stabilization services, how much capacity we need in the state, and just making sure we really have that somewhere to go 3rd pillar. So I think that just kind of lays out where we want to get to and where we are today. And then I think it makes sense for Chris to talk through what that really looks like in practice.
All right, thank you. So I'm going to go over this pretty quick. Whoa, not that quick. Yeah, you can move on to the next one. Who's ever driving? So, prior to 1/1, this is kind of how our system in emergency services across the state operated. And as you see, all of those arrows take you to one place, which is your local hospital emergency department. And from there, they would do an assessment. If they saw some behavioral health illness or concern that they wanted further evaluated, they would call in somebody from the local mental health center. They'd get an assessment. They may be discharged to acute services. They might get just referred out someplace. But there was no clear link. A referral with a phone number is great, but it doesn't kind of guarantee that that follow through happens. Or people would be held either voluntarily awaiting a bed, and I think we've heard about the waits on that, or involuntarily awaiting a bed. And those waits, for adults were, getting up in days. I think we're back down a little bit. And for kids, we've had numerous problems, waits in excess of 3 weeks for kids. And now some places, to try and get them out of the ED, which is not really the place to hold them, there's, agreements made and they go back home and wait for a bed, and just really not ideal. And so go ahead and advance. So as we heard, on the first, we've got a 24/7, access point, and that's call, text. There's a variety of options on that. Teams get deployed by, GPS. So we try to get the closest team out to somebody. But also the access point, beyond connecting to a mental health center's mobile crisis team, they can also access the doorway, law enforcement. But they can also, deal with those social determinants. So they kind of filter and weed those out. So if we would advance one more slide here. So, now the system, instead of, we take that hospital out and we put that rapid response access point in that will get the phone calls and activity. So the police can call them, anybody in the community can call, crisis lines, mobile routes, anything. And they actually do a triage into 4 different levels of response, and the lower levels may be social determinants. So on the lower end of this, you kind of have people may need a case manager, they may need connections for food, they may need right now it's cold, they may need heating, but that can be causing emotional distress, and that will trigger a phone call. And so rather than kind of guessing, wondering who to call, we get that. And then at the far end, we still have the option to use a psychiatric hospitalization for people who need that. But the idea is to try and match people up with what they actually need. And then advance. And this is probably one of the bigger aspects of this right now, anyway, on the launch, is if somebody calls the access point, even if they don't get a mobile crisis team dispatched for them, they're going to get follow-up within 48 hours. Right now, we're generally seeing people within 24 hours. And it's not going to be long-term, but somebody's at least going to be meeting with this person, getting a better understanding, and if necessary, doing some short-term stabilization crisis work, or connecting them with other resources that they need along the lines of social determinants. We've got peer support services, big part of this program to help relate with folks in a different way outside of that traditional mental health intake process, or what some people see as a labeling or stigmatizing process. We may just engage with people with one of our peers who are going to understand the situation and direct accordingly. We can do things in our office. We can do things in the community for that follow-up. I think this was alluded to. There's, crisis apartment and residential programs. We do not have those. That wasn't part of this first round of funding. Hopefully in the future, that kind of crisis model will get here as well. I can't remember if I have another slide or not. I do. So that's busy. I'm going to zoom in on just one part of it. If you can do one more click. And so, you start on that purple, square or oval there. Somebody reaches the access point and they're going to make an assessment of whether or not that caller is in distress and what needs to happen. And if it's yes, there's a whole protocol in that busy first slide you saw there. But they're going to attempt to de-escalate and work with somebody on the phone. If they're not in crisis, they're going to look at the doorways, 211s. If it's just purely social determinants, go to 211. And if it's just for ongoing mental health support, for follow-up, then we'll get outreach at the community mental health center, and we'll get this, and we're going to make a phone call to those people and kind of set up a time and make sure they're they're coming in. So that's kind of where we've arrived in, whatever, we were the 27th. So in 27 days and how the model's working. And I will stop because I probably used up all my time.
And just to let you folks know, timing is great. We're right on time. So
Perfect. Thank you, Pete. So I'm just going to give a brief overview of 211 and the services we provide. We can go to the next slide here, please. So what is 211? It was created in 2000 by the FCC to help individuals, families, and service providers connect with resources in their communities. And today there are active 211 call centers in all 50 states. We can advance here, please. So when someone calls in, we ask for their zip code and their age, and that helps us determine the most appropriate resources in our database for them. If they do not want to provide that, they don't have to. If we need to get an interpreter on the line, we can arrange for that for most languages. And quick fact, New Hampshire 211 is housed by Eversource. Everything we have, our equipment is donated by them. So we definitely are grateful for that. It helps to lower our overhead substantially. Next slide, please. So what we do, we help point people in the right direction. When people call in and describe their situation, they might not always know exactly what could help them. And during that conversation, we can make suggestions based on that. We always try to direct people to the closest resource in their area. Some of the most common organizations we refer out to include community action programs, the doorways and RCOs, homeless shelters, town welfare offices, the VITA program, that's volunteer income tax assistance. And when people call in and their income is 58,000 or less, we can help set them up with an appointment to get their taxes done for free. So that's a very busy time of year for us right now with that going on. Next slide, please. So there are a lot of different reasons people call into 211. Some of the most common are help with housing and shelter, food insecurity, SUD, rent payment assistance, tax appointments, and most recently, over the last 2 years, information about COVID-19 and getting appointments for that reason. When you call for SUD, we can transfer directly to a clinician at their nearest doorway or the on-call clinician at Dartmouth Hitchcock if the call is made after hours. For homeless callers, we can do a brief intake of their information with permission from the caller and transfer that over to a homeless outreach worker in their area. And that person will be contacted by that person to help them arrange for resources. We receive calls for many other reasons. Just in 2020, there were over 750 reasons. As you can see, some of the examples on the screen here. And we can go to the next slide, please. So that's just a visual of the increase in volume over the last few years. As you can see, it's definitely risen a lot, and we're hoping that continues to climb so that we can make a bigger impact here in New Hampshire. So these are the ways to contact us. Obviously, the easiest is calling 211. We have the 866 number in case the cell phone carrier might bounce to a different state. If you are close to Maine, Mass, or Vermont, you might end up picking up their 211 instead. You can text 898-211 if you prefer to text, and you will receive a response via text message as well. And that is basically it. Thank you very much, Ashley.
You can move us forward another slide, Ashley. Awesome. So I don't want to take up too much time so that we leave plenty of time for questions. So I'm going to breeze us through pretty quickly to do a quick overview of Unite Us, what it is, how it works, who's involved, and why your organization should join if you're not currently participating. We can move, yep, perfect. So what it is, Unite Us is a software company. We deliver a technology tool that we consider to be a unifying infrastructure that supports better connection between healthcare, social care, and government programs. We do that through allowing electronic closed loop referral, assessment and care plan management tools, bidirectional communication, as well as alerts for provider to provider interaction, as well as alert tools and functionality for clients being directly referred through the platform. We have organization level exports available to track outcomes at the org level, as well as community-wide dashboard that again informs that bigger picture and community-wide discussion. Can move us forward. So how does it work? What does it look like to connect people to care inside of a Unite Us platform? So I'm going to run us through a quick case study of what this looks like. So let's say that Tom is our client. In this example, he attends peer support at his local recovery community organization. He meets with Stacy, who's a certified recovery support worker. And in her work with Tom, she's supporting his need for recovery support. However, also learns that Tom is experiencing food insecurity. He has a food need, and so she'd like to make a referral on his behalf. She's able to log into the Unite Us system, create a unique client record for Tom if one does not already exist in our database. She's able to gain Tom's opt-in consent right within the platform and then generate an electronic referral on Tom's behalf to one or many food pantries that are available in the network and are in close geographic location to where Tom is located. From there, Stacy is able to view when Tom gets connected with that food pantry. The food pantry updates that referral in Unite Us, and that gives automatic feedback to Stacy. She's also able to have some view into other referrals and other partners that Tom is working with in the network to address other potential co-occurring needs that Tom might have. And again, as Tom is receiving care, those referrals are happening, cases are eventually being closed with an outcome. Stacy continues to receive real-time updates, and she's able to leverage the platform to continue tracking Tom's total journey. You can go to the next slide. Thank you. So who's involved in this network? Quite a few organizations are involved in this network. Some of you may be familiar with Unite Us. So again, these are your like-minded organizations and your partners in the community who are committed to the same thing as you, coordinating care and addressing co-occurring needs. So you'll see a number of logos on the screen that represent who our current network partners are. Again, 250 plus organization locations in our network since we launched in December of 2020 in partnership with the integrated delivery networks, as well as in partnership with our funder, Department of Health and Human Services. And these partners that you're seeing in the network are representing over 300 unique services and programs that are readily available and accepting referrals through the platform and have been since last December of 2020. Can move us forward. So why join the network? Network partners and their clients are seeing the benefits. They're saving time by removing manual process of making referrals and the manual process of having to then follow up without any kind of a closed loop system that's automating feedback to them. It's enhancing care because you're able to leverage the platform to connect clients with resources outside of your own four walls. And of course, you're increasing access because there is an available resource directory that you, as well as clients, can leverage inside of the Unite Us system, as well as our public facing resource directory as well, right through the Unite Us in New Hampshire homepage. And perfect, here's my contact information. I would love for everybody to stay connected, and I'm happy to now hand it back to Pete to facilitate and for us all to respond to any questions that you may have. Thank you.
Wonderful. Thank you all so very much. We're doing great on time. Great, excellent. Amazing, like synthesizing of a lot of information into a, as my clock has it, like 22 minutes. So that was, you all nailed it. Nice work. So I would like to offer individuals to use your raise hand function, if you wouldn't mind. And I'm going to change my view so I can see everyone. if you have any questions, yeah, just please raise your hand and I will call out and I will. So Karen, I am going to go ahead and unmute yourself, Karen, and you can go ahead.
There we go. For a second there, it said that you weren't allowing me to unmute, so thank you. Hi, Pete. So I think this was a great overview of each of the 4 services, and I'm kind of going back to something that was in Chris's slide, where it appeared that someone might call 988, then get referred to 211, maybe to a doorway, etc. I'm seeing, like, if I'm just your community member and I'm just learning about this, I'm wondering how you're not duplicating efforts, and when might I, like, why wouldn't I call Unite, or why wouldn't I connect with Unitas right away? Why wouldn't I connect with the doorway right away? When would I connect? Why would I want to go from 988 to 211 to the doorway, when it sounded like, at least for substance use disorder, we'll say for an example, 988 would be able to connect you to those resources. So I'm looking for some clarification on, you know, how to differentiate when those times would be. Does it, or is it always going to follow that pathway? And just clarification on how services are not going to be duplicated for that initial call. Because I'm thinking I'm a person calling or connecting, and I'm repeating my story maybe 4 times. And that is hard for people that are struggling, right? So
Yeah.
Great question, Karen. I'm happy to start off answering that a little bit.
thanks, Jenny.
This is something we've been thinking a lot about, and we still have yet to do like a big marketing campaign around all of these sort of access numbers to make sure that that's really clear to the community. Part of the weight on that is actually that we're going through a process of having community listening sessions and better understanding, working with cultural brokers and working with special populations as well, you know, and to make sure that that the messaging really hits the mark. So we want to make sure that our messaging both gets everywhere in the state so that everyone, you know, can have equitable access to the system, but also that it makes good sense. So what we didn't want to do is like really rush a message and have it fall short. So I do think we're trying to be really thoughtful about that. But I also think there's a lot of stuff that pieces of this are being marketed, right? Like there is a doorway messaging campaign, and then there's some rapid response attention. And so getting it right is probably a year out. So when I was talking about just thinking about the length of time it takes us to really like do a crisis transformation, it's going to be a little bit longer term where like that. And I think that's true for messaging as well, like where we are just get to a place that's very clear to the public what to do takes a little while, because what we just did was collapse over 30 phone numbers, you know, and that is sort of hard to describe. To be as clear as I can to answer your question, I'll say that's all complicated and yet to come, but to be as clear as I can to answer your question, the rapid response phone number, which today is still 10 digits. So I want to leave people with clear messaging. July 16th of 2022, 988 is going live. New Hampshire does not have control of that, right? That's a national initiative. So that won't happen until July of this year. Then when 988 goes live, it will be answered by accredited Lifeline members. So those member centers today, that's Headrest is accredited, and Beacon, who is the vendor that's operating the rapid response hotline in New Hampshire, they will both get those calls, Headrest and Beacon. So there's a lot of work being done to make sure that the quality of the call is the same no matter where the caller ends up, and that they have access to all the same New Hampshire-based resources, right? But that's what's happening in July. Today, the folks that answer the phone at the rapid response access point are there to de-escalate crisis situations. And that's a bit different than how Vanessa described 211, right? So that crisis de-escalation is where I would say is one of the key differences. So crisis is self-defined. You're going to decide when to call, right? If you feel like yourself or a family member are in crisis, are in emotional distress, or having substance use, mental health, suicidal crisis, then you're calling the rapid response access point, right? If you're looking for housing, if you're looking for recovery supports, if you're able to get an appointment tomorrow kind of thing, that's when I would say to call 211. Vanessa, do you want to comment on that? See, like, is that a fair description?
I don't think I could have answered that any more eloquently. Yes, that's a very fair description.
Thank you.
You're welcome.
Does that help, Karen? Oh, Chris, jump in.
I was just probably the only other thing. I mean, if people are aware of the numbers, they can certainly self-select. I think, you know, what's now a 10-digit, what will become 988. You know, that's going to be marketed, promoted as when you're in some level of distress. So, you know, if your housing situation or you know, food insecurity situation, if that's causing distress, and you know of no other line, 988 is at least going to get you where you need to be. If you know 211 exists and you called them before, you can certainly call them direct. So I'm not sure that it's a decision point, but I think when Vanessa had her slide up of calls, you get a sense of what's happened during the pandemic and the promotion of 211 to get information about, you know, where to get tested, where to get a vaccine. And suddenly now people are aware 211 is out there. I think many people don't really know it exists to begin with. So I think it's some learning curve, and I don't mean to make it muddy, but I think when I look at it, the upside is if you call 988, you're going to get help still, even if that's not the best place to start. And hopefully you'll learn about 211 along the way.
And that, like with everything that we're doing, with every component of this, it takes tons of collaboration. Is the most critical component to our success is making sure that no matter where people go, that we keep it low barrier and that they will be connected to the services that they need, right? So that's, we would hope the end goal here is that it doesn't matter which number you call, because we're going to get you to that place that you need to be, right? So if you need to have a form transfer to actually talk to someone that can do that crisis de-escalation, or if you actually need to be connected to a social determinants of health piece, that you'll get there. And I understand wanting to get there in the least amount of like transfers or retelling your story. Of course, that's also the goal of this system change. And then the one other thing I think I would say though is that the Unite Us piece you did mention in your question, like why wouldn't I call Unite Us directly? Unite Us is meant to be a platform that connects providers. So that's a little bit more like behind the scenes for the public. The client themselves are not connecting directly into that platform. And again, I just defer to you, Nadine, to make sure that's accurate.
Yeah, thanks very much, Jenny. I was going to jump in and offer a little additional context for the role that Unite Us can play too. And Jenny is right. Primarily, the Unite Us tool is provider to provider facing, with also some hub support, right? So some additional support from Unite Us to help navigate referrals that are getting sort of caught in a loop and imagine that referral is landing potentially in the wrong hands or with the wrong organization. One other thing I will mention, Jenny, just to piggyback, is that we do now have an assistance request form that does allow clients to self-refer into the platform. So if a client is currently seeking services and they do land on the Unite Us in New Hampshire website, they can submit a web-based form, which is essentially their own way of referring into the network to support requests to be connected with services.
So I appreciate all that. And I guess I had my provider hat on, you know, when I was thinking about Unite Us. But it's interesting. It's still interesting because there is that self-referral form. So, but overall, like, and maybe it's going to be part of the marketing. I know a lot of people have become familiar with 211, and so they know to call 211, even for substance use disorder now. There'll probably be a shift in that, but just like what you said, Chris, it sounds like, you know, each number will get you to the right place, hopefully with not multiple transfers. That's kind of the goal, I think.
Well, and it's really interesting if I, as facilitator, I can jump in here real quick. I was working on some of the 988 planning subcommittees, and you know, spend a lot of time just on color coding the triaging matrix, if you would, from green to red. And if a call comes in, regardless of where it lands, how that receiver of the call like translates that, triages it, and connects it to the right point. That's the upfront beauty of all this. The backs, the sort of the backstory is, how do we as a community then assure that duplication isn't happening, right? Because the phone number can only do so much. Unitas can play that part, and then the individuals in our community have to have those relationships too. So we are all on the same page in terms of Tom. I think Tom was your example, Nadine, in your video. Tom isn't, not only telling his story 3 to 4 times, but he's getting bounced around to here and there, and duplication of work. So, and that's part of what the doorways are challenged to do within the SUD space. But yeah, there's going to be this continued sort of effort in terms of creating and collaboration, if you would, community-wide as well. Yeah.
Thank you.
I do think too, even though it still sounds confusing, there were 30 phone numbers. So really, again, just to say, we're a little bit confused on how to market the 3, but I think we're in a better place than we were in December.
Absolutely, absolutely. And could we, just for clarification, Chris, could you go back through, and I don't know if we can get that slide back up again, but if you could just restate, if I called 211, right, or if I call that hub in that perfect world, what happens to my call?
It's better if I unmute, isn't it? So that's the, whoops, that was the slide. So, in the perfect world, click again so it advances. There you go. In the perfect world, that call is going to get some upfront triage by a master's level clinician to determine if there is a crisis that needs some level of de-escalation, or if really what the call is tied to somebody who's looking for substance use services. I'm okay now. I really need to get some mental health treatment. I don't have money to pay rent this month. I need to move. I can't afford this apartment. I need a new apartment. I don't have any food. How do I, all of those things. And so, if there's a crisis going on, it's going to follow this other whole path to the right at the bottom of the screen there. And that's going to get into, some stabilization, potentially mobile crisis team, potentially, calling law enforcement to make sure the situation's safe, secure. There's a bunch that goes with that. If it's not that type, then there's going to be some, parsing out of who do I need to connect this person with? Are they looking for substance use services? We're going to connect them up with either the doorway or 211, depending on the time of the call. If it's, if it is really a social determinant, I need a resource, where are the various food pantries? How do I get a heating subsidy? How do, all of those things that will get transferred to 211. Somebody who's looking for mental health services, but doesn't really know where to turn, that's going to get referred out to the local mental health center in their region, and we'll do follow-up from there. So that's kind of an ideal world, what's going to happen with those calls as they come in.
No, that's great. And I think in the name of transparency and lack of in clarity, I just wanted to review this again for everyone viewing, just so they knew kind of, the ideal state. Are there any other questions out there? Folks, feel free to raise your hand and ask away. We'd love to hear from you. I don't see any. I'm curious if you all just real quick can speak towards just any uptick in volume. I know, Vanessa, you had shown the 2020 slides and that increase, but like in the most recent 2021 into early 2022 with the 988, I know they've even had calls right to 988. Could we just get some volume check on where we are with these different numbers?
Sure. So for the 2021 numbers, they were roughly about the same as 2020 for volume. And I think that's because it was not the height of the pandemic anymore. So we weren't getting as many COVID calls. I will say for SUD related calls specifically, we've seen about a threefold increase since last June. So that is definitely going up quite a bit.
The first, I'll say, and I don't have current numbers, we're going to get a report mid-February, but just to give you an idea, the first 10 days for the access point, they had over 1,300 calls come in with, I think it was like 170 dispatches for mobile crisis. So, you know, you may be hearing rumblings depending on which meetings you're at and who you're talking to about bumps in the road. And certainly they exist. And we're working through those, I think, collectively. But when I look at it just locally, because I'll speak for what I know of our system in Stratford County, since I've been at Community Partners, we have not had weekend appointments for people, right? So now if you're calling the access point and you need to work with somebody or talk with somebody, even if you don't need a mobile team to go out, we're going to be able to see you on weekends. And that's something hasn't had in, you know, over 10 years. So yes, it's not perfect, but there've been a lot of, you know, very positive steps and changes to make access much easier for people. And we're not fully, you know, running up to speed yet. So.
Excellent. So the volume is up, you know, and hopefully utilization sort of will continue to increase this sort of need, right? The show of need, and we can continue to expand those services. That's fantastic. I do have a question in the chat from Nicole, and she's asking if an individual presents, say 2 o'clock in the morning in a law enforcement sort of organization or location, do they then call 211 and 988? Or how does that interaction work from the say law enforcement end?
So they can, I'll put it this way, they can call the 10-digit access point number and they will get, if you will, an expedited dispatch to the available team. I think depending on where you are in the state, at 2 in the morning, there are different realities for law enforcement. So Dover has more capacity to make that call and stay on the scene until somebody arrives than maybe Milton or Lee, where I've been informed they have one officer on patrol overnight like that. And so, you know, right now, as we're learning through this, they may or may not be able to take that time. And so they may default to their, you know, traditional, if they feel that something needs to happen, they may still default to the hospital. Other communities, when you get, you know, more rural you know, they contract with the state police. So they don't necessarily even have an officer local to get there to begin with. And then that state police certainly has a broader area to cover that they may also not tie themselves up. So I think it depends what region you're in, what city you're in, what their capacity is, and how that's going to play out. But certainly the system is available for them, but I think the nuance will play out and develop over time.
So if you need police, ambulance, fire on scene, you call 911 still for sure, right? But then if there's law enforcement on scene who believe they could benefit the situation to benefit from a behavioral health team, they can call the access point and ask for mobile crisis to be deployed to their location. And that happens that when you say that expedited process, like instead of going through a de-escalation process that may have somebody on the phone for 45 minutes, right? They're instead going to deploy that team to law enforcement's location. That in theory. And then like Chris pointed out, but we do have Department of Safety, Department of Justice, 911 dispatch, AG's office, you know, state police are all part of the 988 planning coalition. So great partners and trying to figure out the nuance to what our law enforcement situation across the state looks like.
Nicole, does that satisfy your question, you feel?
Well, we'll put it to the test at some point, I'm sure. Not that I want to, but this is what I've been in touch with Nadine. I've been, you know, reaching out. We've been trying to figure out the best spot where we are taking those individuals at 2 o'clock in the morning and handing them warmly to someone. And this is what we're trying desperately to do, is work with these systems that are getting in place. So we'll see, you know, between us and Dover and Somersworth and everybody else out there at 2 o'clock in the morning, how many of us will have the call? We don't know. So that mobile crisis team could be running every which way or not. I don't know. So it's to be
That's
seen.
happening today. Law enforcement is calling, Nicole, and you are, you know, it is, yeah, you can call now the access point, and you would definitely call the access point, not 211 at 2 a.m. when you want a mental health, you know, clinician to come out.
Right. So we'll put it to the test, I'm sure.
And then if you have a moment, please loop back and tell us your experience too, because again, when we're doing anything, big changes like this, we have to do quality improvement over time. So if you are able to tell us how that went when it tested, please do so.
Thank you.
Awesome. Thank you, everyone. And I would like, so we've reached our time. I want to thank you all for your amazing questions, the amazing material presented. I would like to just say that, Nadine, if there's a way for us to get your contact, I know it was on the slide deck, but if individuals are interested in contacting you, Ashley, we can figure out a way to get that contact information out to attendees. So thank you all so much. And Ashley, it is all